സൂസി മാഡം എന്ന് പറഞ്ഞാല് ഞങ്ങൾക്ക് വീണ് കിട്ടിയ ഒരു സൗഭാഗ്യമായിട്ടാണ് കരുതുന്നത്. Madam is always interested in taking classes, and that too, she conveys points very clearly. വളരെ ക്ലാരിറ്റിയോട് കൂടി ഐഡിയാസ് കൺവേ ചെയ്യുന്ന കാര്യത്തിൽ she is very successful. And Susi Madam has introduced us to point of care ultrasound. അങ്ങനെ ഒരുപാട് കാര്യങ്ങൾ നമുക്ക് പറഞ്ഞു തന്നിട്ടുണ്ട്. അപ്പം ഇപ്പൊ നമുക്ക് ഇന്നിപ്പോ വെന്റിലേഷൻ, ഷീസ് ടേക്കിംഗ് us through path of ventilation. So welcome madam. Okay, we'll start.
Madam, thank you madam for the kind words. Okay, so we'll begin with the topic of Hhfnc, and after that, am I clear?
I'm clear.
Okay. So after going through the tiring sections of invasive ventilation, now we are little bit liberated because Hhfnc is a non-invasive ventilation. So we are not showing this in the workstation. So I thought I will just give a brief theoretical introduction to Hhfnc. And we had also taken a live video, which is told by Dr. Anu, who is our assistant professor in the Department of Pediatrics. So I'll try to share it after my talk. So we'll go directly to the talk. So as you all know, Hhfnc is high flow, humidified, heated nasal cannula. Okay, or you can take any H in the beginning, like it could be heated, humidified, and high flow cannula. So you'll understand the importance of all three H's as I show my subsequent slides. Okay, so I thought before entering into the topic proper, I have to make you understand regarding, because here as you see, it is not very cumbersome. That's why in my first slide I have put up the smiling child who has kept this is the interface. This is the interface of the Hhfnc, which looks like a nasal cannula, and the child is smiling. So he's actually tolerating it. There is no much pain or no much problem with that. And that is why it is actually patient friendly, doctor friendly, nurse friendly. Even nurse is happy. If you tell a nurse to set up that you want to put a patient on a ventilator or a non-invasive ventilation, she will be like, she has to do so many things. But if you tell her to put a child on Hhfnc, it's easy to put. Okay, so that is why it is friendly. And coming to the lowermost portion, you can see the humidifier along with the heater. That is the main heart of Hhfnc machine. Okay, and top I have put up the cannula. And this cannula, you have to understand, it looks like a nasal cannula, but it's more costlier than our simple nasal cannula. Our simple nasal cannula costs around 60 to 100 rupees depending upon the different brands. But this is made up of a special material and it is king-free. And this will cost around 2,000 rupees. So we are mainly disinfecting it and making it use. But if the bystanders are willing to buy it, it's actually one use. You can use it for your children. Okay. So nasal cannula, I think PGs are there. Why I'm going to show you this. What is this? Neetu is there. Neetu, what is this? I'm depicting on my screen. Anybody, any of the PGs can answer quickly so that we can finish it fast. Because asking questions and waiting for the answer takes a lot of time. So what is this? Anybody? Ramisa, someone answer. Huh? This is a simple. This is a nasal cannula attached to a central oxygen point. Clear? So this is an oxygen point you are attaching to the wall. And there is a nasal cannula attached to it. Clear? So this is along with the pressure barometer, and this is an oxygen source. Okay. And this is a simple nasal cannula which we are using. Why I have shown this is, you all know that when we are breathing air, we are taking in oxygen, which is actually present in air only as 21%. Okay. and we are happy, like our lungs and heart are working normally, this 21% of FiO2 is just enough to maintain our PaO2 and SpO2. Clear? But when our lungs are diseased or our hemodynamic status is unstable, this 21% oxygen is not enough to maintain the saturation. Okay, so we need additional oxygen. So when we are actually plugging it on to a oxygen source, what is the percentage of oxygen which your child will be getting? What is the percentage of oxygen which you are extracting from your point? Tell soon. See, all of you can unmute one by one and can tell instead of me telling the names. What is the oxygen percentage which you are getting from the central oxygen suction port? What percentage of oxygen? This is received from the oxygen plant directly. So what is the percentage of oxygen here? In air, we are breathing only 21%. So what will be the oxygen here? Ramisa is near me, sitting along with me. I'm seeing her. But how much percentage of oxygen is got from the central oxygen source? 100%. So 100% is got from the central oxygen source, and you are going to give the patient it through a nasal cannula. So how much percentage the child will receive? Will the child receive this 100% oxygen? No. So that depends upon what interface you are using. Instead of the interface, you can tell what is the type of oxygen delivery device you are using. So this is the oxygen delivery device, which is the oxygen prong, which is a low flow device. Okay, I'll tell about all these terms. So this is 100% oxygen from the central section, and you are giving it through an oxygen delivery device like O2 prong. What is the percentage? That is FiO2. FiO2 is the fraction of inspired oxygen your child will be getting. Any idea? First is Kartika. Kartika is there. What is the FiO2 your patient will be getting through a nasal cannula? Simple nasal cannula. Nasal cannula, what is the percentage of FiO2 your child is getting?
ma'am.
Guess you are using nasal cannula left and right from your first year. So this is 100% coming from the central oxygen. And approximate, okay, what is the FiO2 you get in a facial when you give it through the face mask? Asna, face mask la entra kittum? ആരും പറയണില്ല. See, a face mask most of the children sometimes won't tolerate in face mask. In face mask, if you keep it very tight, you will deliver about 60%. And if it is loose, it will deliver 40%. Clear? Nasal cannula also, it will deliver only somewhere between 40 to 60 or even lesser than that. So this is just to show you or understand you that even though we are taking the oxygen from a central oxygen point where it is 100% oxygen, by the time you give it to the patient, depending upon the oxygen delivery device, the FiO2 can vary. Okay, that means you understand. Maximum 4 liter is be permissible through this nasal cannula, because more than 4 liter the child cannot tolerate. Okay, why the child cannot tolerate this? Why the child cannot tolerate is the secretions will become, because this oxygen you are delivering, is it humidified and is it warm? No. So that is point you have to understand. This oxygen you are delivering is dry oxygen and it is not warm also. It is cold oxygen. And one more thing. See, you have seen that this oxygen trap being filled with distilled water, isn't it? That distilled water filling of the oxygen trap will not make the oxygen humidified. Clear? So actually, the latest consensus is this is not to make the oxygen humidified. This is only to make you see. That is, when you open up this oxygen trap, if you see bubbles here, you are sure that the oxygen is flowing. You keep it at 2 liter, there will be little bubble. You'll keep it at 4 liter, more bubbling, and 6 and 10 liters, there will be more bubbling. Okay, just to see that only. And the reason consensus is that you needn't add water in this oxygen trap, because if your sisters and if your ICU is not very careful from patient to patient in removing it and maintaining a proper aseptic precautions, you will get hospital-acquired infection. Clear? So that point is very clear, that the oxygen you are getting from the central oxygen point is dry oxygen, and it is also not humidified. So when you are giving it through the nasal cannula, maximum permissible rate is only 4 liter, because beyond 4 liter, the child cannot tolerate it, drying of secretions will occur, resistance will increase, and you cannot, and that will actually impede the fraction of inspired oxygen delivered. Is it clear? Okay, so this is from yesteryears. This is a short, what is that? Easy understanding of what is the oxygen or FiO2 delivered in different liters. I have written only up to 4 liters because maximum permissible in a nasal cannula is 4 liters. So this is actually, I'll be telling, this is actually rough consensus in the adult or older children or adult. Because, you know, as I already told you, the air contains 21% of oxygen. Every 1 liter of oxygen will increase the FiO2 by 4. Clear? So 1 liter oxygen you give, the FiO2 has increased from 21 to 25, increased by 4. 2 liter, again it has increased to 4, that is 29. 3 liter, 33. 4 liter, 30. Understood? So this is a rough consensus which was developed in children, older children and adults. And maximum of 4, you are giving maximum FiO2 is 7. That is assumption in adult. But I can tell you from means from the next slide, things will be more better. So if you just understand that this is FiO2 delivered in a simple nasal cannula. Okay. Now I have been telling like low flow and high flow, because this Hhfnc 1H is actually high flow. So you should know what is this low flow, what is this high flow. Is it based on any concrete values? Then only there should be a concrete value, and based on that value, it's more than that, so it is low flow, high flow. It's less than that, it is low flow. Is there any values, anyone? So what is this high flow and low flow based on? Nobody is answering. Why? Dakshina is entered the waiting room. Please admit her. Jahid, what is the thing which is based on this low flow and high flow? Any idea? Not FiO. Okay, FiO2, it is based on FiO2 in the sense that high flow devices will deliver high FiO2 and low flow devices will deliver low FiO2. Good. Anything which is based on, that is above this much liters, it is high flow. Above this much liter, below that much liter, it is low flow. It is based on a patient's or a normal person's alveolar ventilation. Clear? So based on the minute ventilation or alveolar ventilation, it is classified as low flow and high flow. And all of you know alveolar ventilation is tidal volume into respiratory rate. Clear? So let me actually tell you that yesterday even I was telling about dead space. The concept of dead space is also important when you ventilate. This is tidal volume into respiratory rate. When you have what is a dead space? Last time also I was asking, what is the dead space? Yeah, so the air is getting collected in the conducting system or even in the alveoli, but there is no gas exchange taking place. That is, oxygen is not getting absorbed, carbon dioxide is not getting washed off. And you have two types of dead space. One is a anatomical dead space and one is a physiological dead space. Anatomical dead space is your larger airways, the trachea, bronchus and all, where only air is getting in, but there is no exchange taking place. And a physiological dead space is present within the, because alveoli will contain air, but sometimes the blood will not flow. Or it can be reversed. Blood will flow, but the alveoli does not contain air. Okay. So these dead spaces will actually add to the problem. So when there is a maximum dead space, as Shija madam was telling that humidifier and moisture, everything is attached to the limb of the ventilator, actually it is adding to the expiratory tidal volume is decreasing. Clear? So alveolar ventilation is tidal volume into respiratory rate. And when the dead space comes, this tidal volume minus dead space. Is it clear? So when dead space increases, your alveolar ventilation is decreasing. You should know that, because one of the mechanisms of your HHFNC is to decrease the dead space. I'll be telling about it. So low flow oxygen delivery devices and high flow oxygen delivery devices are actually based on the minute ventilation. So you have a minute ventilation. Suppose like adult, Zahid has got a tidal volume of 500. He is respiring at 20. So what is your minute ventilation? 500 into 20, which is 10,000, which is 10 liters. So your alveolar ventilation is 10 liters. Is it clear? Now you are given a nasal cannula with 4 liters. It becomes a low flow device. Clear? Your alveolar ventilation is 10 liters, but you are putting a nasal cannula with only 4 liters. 4 liter is less than 10 liter. So that becomes what type of device? Low flow device. Is it clear? Now Jahid has got a alveolar ventilation of 10 liter. Jahid is put on an HHFNC with a 40 liter. So what is that? This 40 liter is more than his alveolar ventilation. So HHFNC becomes a high flow device. Is it clear? So this high flow devices are based on above or below the alveolar ventilation of that particular person in the particular disease condition. That is also very important. Because suppose Jahid is having pneumonia, what will happen to his tidal volume? It will decrease. What will happen to his respiratory rate? It will increase because he will have tachypnea retractions. Clear? So in that scenario, it again depends upon your tidal volume and respiratory rate in the disease condition. And in that disease condition, if you put a flow above it, that is high flow. And if you put a flow below, it is low flow. Okay, this much is understood. So piece by piece, we'll learn. So this again, I'm concentrating on the oxygen meter, right? Because you feel like you are giving 100% oxygen and you assume that all your patients will be getting 100% oxygen. That is not occurring. Okay. Now, what is this? Ramisa, what is this?
Face mask.
Okay, it is a simple face mask. Okay, what is this?
NRB.
Yeah, it is an NRM mask. Okay, so that is a non-rebreathing mask. So there is a difference between the face mask and the NRM mask. Face mask is a low flow device, but NRM is a high flow device. So you understood. In face mask, you need to put something only below the alveolar ventilation. 4 liter or 5 liter is enough. And depending upon the condition, we'll bring it down to 2 liter. But in an NRM, you have to put a high flow because only if you put a high flow, you see this reservoir. This reservoir will get filled with oxygen. Clear? So in an NRM mask, you have to put it at 10 liter. Okay, and if you put it at even more than 10 to 15 liter, this will actually, the oxygen is actually entering here and this is getting filled with 100% oxygen. Is it clear? So this is getting filled with 100% oxygen and there is a valve over here so that expiration does not reach into the valve. So whatever the patient is inspiring is 100% and only 100% oxygen. Tiriche expiration, there is a valve here so that it is rebreathing does not. So that is why rebreathing mask, Rega madam was telling you use it for delivering high FiO2 before you intubate the patient in the pre-oxygenation. Is it clear? So face mask will deliver somewhere between 40 to 60, but NRM mask is going to deliver 90 to 100%. So this is a low flow device and this is a high flow device. Is it clear? So this is a non-rebreather mask and this is a simple face mask. And what is this? What is this acting as food? This is a high flow device. And you know, actually the hood should be in such a way that we have 2 portholes also. Because otherwise, you cannot decrease the flow rate. Because if you decrease the flow rate, there will be rebreathing. Okay, so ideally, a hood should have 2 portholes. This is also a high flow device and you are using it in newborn. And you close the 2 portholes, you will deliver almost 90, more than 90, 95, 100%. Okay. And what is this last one? What is the last one? It's the Venturi. Okay, and this Venturi is also a high flow device. Is it clear? So that is just I have shown the difference between low flow and high flow for you to understand the actual difference between the two. Okay, so is it? So that is actually determining, as I told you, FiO2. Okay, so high flow devices will deliver more FiO2 and low flow devices will deliver low FiO2 in spite of you giving it from the same oxygen port where it is 100%. Is it clear? Okay, with this basics, we'll go forward. And this is actually the definition of HFNC, which has been described in the Cochrane review in 2040. Okay, so just I have highlighted the important red things. That is, it is a heated and it is humidified. And it's a blended. Blended means there is both air and oxygen. And what is the interface you are delivering? It's a nasal cannula. And see, it is not written high flow rate anywhere here. Because the flow rate varies depending upon the size of the person and the disease condition. So we have written the different flow rate more than 2 liters per minute only. And then what is a red highlighted? High concentration of oxygen or fixed oxygen concentration, because you cannot tell high, because in HFNC you are giving blended and you can see the FiO2 on that panel. So your FiO2 is kept at 45. You are damn sure that this 45 will reach the patient. Is it clear? But we are not sure in other devices. In HFNC, if you keep it at 45, 45 will enter into the patient. I'll tell more about it in my subsequent slides. So high concentration or fixed concentration of you don't want to give oxygen 100 to a patient. What will happen if you give 100% oxygen to a patient for half an hour or 1 minute? 1 hour. Kiran is there, Kiran Kumar. Because Ramisa and Jahid is sitting next to me, I'm asking them, Kiran, what will happen if you give a patient 100% oxygen for a couple of hours? Kiran Kumar?
No, oxygen injury.
Okay, injury will occur. Okay, that will occur. Apart from that, because injury and
oxygen free radical.
Okay, oxygen free radical injury will occur. Kiran, along with that, what else? What will happen if you want? That is the same mechanism which we need.
Secretions will dry.
Secretions will dry depend upon, because you are giving your oxygen humidified and heated, it will not dry. Clear? This is the same mechanism made use of in, if it is not a tension pneumothorax, a mild to moderate pneumothorax, you give just oxygen only. What happens when you give oxygen? You know, Shrija madam also was telling about the, what is that, apneic oxygenation. That is a concept. Your alveoli is naturally filled with air which contains more nitrogen, isn't it? So when you give more oxygen, this will be absorbed very fast into the blood system. So there will be atelectasis. Clear? So if you give 100% oxygen for a couple of hours together, it not only causes an oxygen toxicity like an oxygen free radical injury, it will cause atelectasis. Okay, I think tomorrow in the case scenario discussion, you will understand more about it. If you give, so that is why we don't want to give 100% oxygen to any patient. You are ventilating a child, you are putting a child on HFNC, you are putting a child on NIV. We always want the FiO2 to go only up to 40. Maximum in ARDS and other conditions, you make it go up to 60. But as the condition improves, the first parameter which you will try to bring down is your FiO2. Is it clear? So oxygen is a drug. Use it cautiously. It is very precious thing. You shouldn't waste oxygen. Okay, only for needed you should give. Otherwise, it can cause problem. And then what is the fourth thing? That it causes a distending pressure. You will understand that it is able, when you give the air at a very high flow, it is creating a positive end expiratory. That is a P. So understood. So HFNC is why this, I'll explain on this. So it is heated, humidified, blended with air and oxygen, given through a nasal cannula, and it is given at a, because this more than or equal to 2 liters and a fixed concentration of oxygen, and it will also cause a distending pressure. Clear? Now a few words, because you should understand you are in the newborn also. 2 liters per minute given through a simple nasal cannula. Asna is there? Asna, this question for you. 2 liters per minute, 2 liters per minute of oxygen, you are giving it to a 2.5 kg newborn baby through a simple nasal cannula. What is FiO2 delivered to the baby?
29%.
Only 29%. Why, Asna? What is, I told you now, this depends upon the alveolar ventilation of that particular baby.
Yes.
Suppose the baby is not having any lung condition. What is the alveolar ventilation? Tidal volume into
The tidal volume
respiratory
into
rate.
respiratory rate.
Okay, what is the tidal volume of a 2.5? Okay, for easy multiplication, take it as 3 kg. 3 kg baby, what is the tidal volume? What is the tidal volume of a newborn? You tell it as 5 to 7 or 5 to 8 ml per kg, isn't it? So if you take it as 7 ml per kg, 7 into 3 is 21, isn't it? 21 is the tidal volume. What is the respiratory rate of a newborn?
60 around.
Okay, you are taking it
40.
60. Okay, you take 40 to 60.
40 to
So
60.
20. Okay, 20 into 60. You take it in the upper way. 20 into 60 will come to around
1,200.
1,200. 20 into 40 will come around 800.
800.
So the minute ventilation of the newborn is only 800 to 1.2 liters per minute. Clear?
Yes.
Is it clear?
Yes. Ma'am. Yes,
And now
ma'am.
you are giving to the newborn 2 liter or 3 liter through the simple nasal cannula. That is going to act as what flow
High
device?
flow system.
High
High
flow
flow devices.
Yeah, it is going to act as a high flow device in the newborn. And the FiO2 delivered to the newborn will be how much?
More
High or low?
9 to 100.
Yeah, not 90 to 100. That is little more. Okay, you can deliver up to 80. So you have to be cautious. You should know about it. Understand? So even
Yes,
a
ma'am.
simple nasal cannula will act as a high flow device in a newborn. So you have to be very careful when giving oxygen to newborn, because you know all the retinopathy of prematurity, BPD, etc. is related to oxygen. Is it clear? So that
Yes,
is
ma'am.
why in the definition they have included more than or equal to 2 liter, because it depends upon the alveolar ventilation depending upon the size. Is this much clear?
Yes, ma'am.
We'll go forward. So that is a non-invasive. That is your Hhfnc is a non-invasive respiratory support modality which uses nasal cannula as the interface. Clear? Simple sentence. So now I'll explain heated. Heated means you have to heat and warm the air. Warm the oxygen you are giving to 34 to 37. And you have to humidify. Okay. So you have to humidify it to 100% of the relative humidity. And the third one is the high flow. I told you high flow and low flow depends according to the alveolar ventilation of a particular patient and with a particular disease condition. Okay. So the high flow you set for that particular patient should be higher than the asna. It should be higher than the asna boyo. Asna. It should be higher than the
Then the inspiratory demand.
അത് ഇവിടുന്ന് വായിച്ചു ഇൻസ്പിറേറ്ററി ഡിമാൻഡ് ഓർ ദ ആൽവിയോളർ വെന്റിലേഷൻ മിനിറ്റ് വെന്റിലേഷൻ ക്ലിയർ ക്ലിയർ അതുകൊണ്ടാണ് വേർഡിങ്സ് മാറ്റിയിട്ട് ടു ആസ്ക് യു ക്വസ്റ്റ്യൻസ് ഓക്കെ സോ വാട്ട് ഈസ് ദിസ് ഹസ്ന this is the this is our very famous cannula, and be careful in the ICU in the newborn when you deal with it. It's costlier. Simple cannula polalla 2,500 rupees ആണ്. So handle it with care. ഒരു കാര്യങ്ങളും you have to handle everything with care because it is costlier. So we are disinfecting and taking it. Okay, so this is a king-free. See, this is a king-free cannula, and this is very flexible, very patient-friendly. It's non-traumatic. And again, I am showing the face of the child who is happy, and this is Hhfnc setup. I think it will be discussed in the subsequent slides or by the video by Dr. Anand. Okay, so it is heated, humidified, and high flow. And it is using a nasal cannula as an interface. It's a non-invasive respiratory support. Clear? Okay, so now this already I have written at the top. It is forming a bridge between low flow oxygen and nasal CPAP. Already I have told. Why it is forming a bridge? What do you understand by that? What do you understand by that? Vaishnavi, what do you understand by bridge between low flow oxygen therapies and nasal CPAP? Vaishnavi is not there. Neetu? Neetu, Farun? Neetu, why it's called as a bridge between low flow oxygen and nasal CPAP, or even the higher escalator, that is the NIV? That means it is superior or inferior to your conventional low flow oxygen? Those sitting near me are telling the answer. It is Neetu.
Superior, ma.
Yeah, it is superior to your low flow oxygen. Adalli itrayin nan explain cheythathu. And it is superior or inferior to your nasal CPAP or NIV? Neetu.
Yes, ma'am. Superior.
Superior to nasal CPAP. What is Neetu? Is it superior to nasal CPAP, or might be there are many studies going on with Hhfnc?
Superior to low flow oxygen, but inferior to nasal CPAP.
Very good. Why it is inferior to nasal CPAP? What could be the reason? Because it's actually a topic of research. Actually, it's a good topic for research if you do a randomized control trial, RCT, between Hhfnc and nasal CPAP. Okay, because even 10 or a decade item, there are no much studies to have a robust thing. But few of the studies have come up like Hfnc is almost in par with nasal CPAP, but many studies have shown it is inferior. What could be the reason, Neetu? Hfnc ഇത്രയും കാര്യം, it is heated, it is humidified, it is high flow. And what does the same thing, nasal CPAP, if it is a bubble CPAP which you are using in your newborn, which has got an inbuilt humidifier and a heater, it is definitely superior. Is it clear? But the indigenous CPAP we are using, indigenous CPAP does not have a heating and humidifying. So that will be, depends. You have to actually find out. Because I told you, I'll be telling in my subsequent slide, mere heating and humidifying itself is going to make a lot of difference. Clear? Heating, humidifying itself is going to make a lot of difference. Neetu, nasal CPAP, what are you giving actually to the patient? Are you giving a high flow?
Nasal. No, ma'am.
Nasal CPAP, no, you are not giving high flow.
High flow.
You are setting it somewhere around 4 to 6 only. But what you are giving is, in that underwater seal, you are setting up a water level which is 4 or 5 centimeter, so that in the expiratory limb, so that when the child is expiring, there is a positive pressure setup. Is it clear? So you are almost definite in a CPAP that you are delivering the adequate, continuous positive airway pressure at end expiration. So you are very sure that you are giving a PEEP. Clear? But what is happening in Hfnc? That PEEP delivery is questionable. It depends upon the flow rate, the nasal cannula size, the mouth opening, etc. of the patient. Is it clear? So that is why the simple nasal cannula and simple face mask on one side, your what is that, CPAP and CPAP on other side, and Nadka you have your Hfnc. Okay, so this last picture I put up just to show you the indigenous CPAP. Just look at my cursor. This is a baby, and the baby is having that what is that? And when you put Neetu, when you put a CPAP, what is the cannula you are using? Neetu?
Madam.
What cannula you are using when you put a CPAP? You are putting which cannula? Which nasal cannula? Tough ആയിട്ടുള്ള question അല്ലല്ലോ. Simple things അല്ലേ. നമ്മൾ day to day practice ചെയ്യുന്നതല്ലേ. What cannula you are using? Neetu? You are using the simple nasal cannula itself, but we are making sure that the cannula diameter is bigger enough so that it is snugly fitting in the nostril, because you don't want a pressure leak from there to occur. Is it clear? And this is the underwater in which we are setting up a definite pressure of 5 or 6 or 4, whatever we want. And you are almost definite that this much pressure is given as the end expiratory pressure. Clear? So that is the difference between CPAP. This is the indigenous CPAP. But the problem with indigenous CPAP is again that you are connecting it to a central oxygen, which is dry. The oxygen you take from there is dry. The oxygen you take from there is cold. So that is adding its own damages. But it is making sure that it is delivering a PEEP. Is it clear? So it is, and this side just included in order to show your newborns who are being kept with a CPAP or a nasal NIV and all sort of sophisticated plastic velcro which has to be attached to the head, very Herculean thing. And this is very distressing to newborn also, distressing to the nurses also, and interferes with feeding, your KMC, everything. So compared to that, see the child with Hfnc, very happy, and less traumatic. Okay. So now we come to the actual mechanism of action. So Samiha. So what is the mechanism of action? So we can act. Samiha is a Samiha, Saira. എല്ലാരും ഉറങ്ങിയോ? സമീഹ, സൈറ, പേര് പറ ബാക്കി. ഫറൂഖ് ഇല്ലേ? Why nobody is wanting to answer? Then I will just finish off. I am not interacting. I am going to complete it very fast. Okay, so what is H? H is standing for heated and humidified. Okay, so heating and humidification with 100% relative humidity is doing a lot of things. Because as I already told you, when you give you yourself feel like you are being kept a nasal prong, and somebody is going to give a cold air and a dry air. You cannot tolerate it. You cannot tolerate it for even 1 hour. Okay, so that is the problem, because if you are giving it without heating and humidification, it's going to increase the resistance right from the nasopharyngeal to the airways. So naturally, all your resistance will be increased. That itself will impair the ventilation. Is it clear? Then second, a mnemonic use mechanism of action. H is heated and humidified. I, inspiratory demands. That is what I already told you. What is inspiratory demand? You are keeping a flow, high flow more than the alveolar ventilation. So when you're keeping a high flow more than the alveolar ventilation, and you are keeping the Hhfnc cannula, which is covering only 50% of the nares, there is a chance that the other air is entering through the remaining part of the nostril. Clear? So what will happen? That is why I told, when you're keeping it at a very high rate, through the cannula, you are suppose it's a newborn, suppose it's a 10 kg child, through the cannula, you are keeping up at like 20 liter. But the alveolar ventilation of the child is only 6 liter or 8 liter. So it is kept at a high flow. So naturally, this liter will not enter inside. So the inspiratory demands are actually met, and that is why if you're keeping the Hhfnc at 45 FiO2, the 45 FiO2 will be correctly delivered to the child. Okay. And functional residual capacity. That is what I told you. It will deliver a fixed. It will not deliver a fixed beef. Okay. It will deliver some amount of vary depending upon the flow, the size of the cannula, and the mouth opening. And L stands for lighter. The other one is very cumbersome. NIV, etc. attached. It is weight. It is heavier. But this is very light cannula which can be fitting on the face. So that is L stands for lighter. And O is the oxygen dilution. This is the same thing which I have told you before. And I think in the coming slides, I have a picture on it so that things will become clear. And W is the washout of the dead space. This is most important. And even if you don't give, even if the P part is not working in Hhfnc, the heating, the humidification, the less amount of oxygen dilution and washing out of the dead space is playing a very important role, which is playing very superior role in maintaining the oxygenation of the child. Clear? So this is a mnemonic for high flow. Okay. So I think the oxygen dilution, I will just show it with a picture so that better you will understand. So this is a head. This is the nares and this is the nasopharynx. Is it, Ramesha? Clear, na? So this is the mouth and this is the oropharynx. Both of them are coming and opening. This is the epiglottis and this is the, just look at my cursor. This is the trachea. Okay. So now, this is like 20 liter. What does this 20 liter tell? The wide out the air, that is this patient's minute ventilation. Is it clear? This patient's minute ventilation and this patient's oxygen got from that air. How much is it? 21%. So 21% of oxygen, but he is breathing at 20 liters. Jahid, so how come 20 liter is? Suppose tidal volume is 500. Okay. His respiratory rate should be 40. So 500 into 40 will come to 20 liters. So he is breathing at, I had told about Jahid's example. Jahid was breathing at 10 liter. His alveolar ventilation was 10 liter. Instead of that, I took it as 20 liter. But he is breathing only 21% oxygen. Clear? Now, to him, we have kept a device which is delivering what is a flow? 6 liter. But you have kept the, what is a 6 liter giving 45%. Clear? Just look here. So 6 liter is giving 45%. Then 20 liter is giving 21%. Both of them will go inside. Who will dominate here in the airway? The one with the flow rate which is more. Is it clear? So this 20 liter is flow rate is more. So this 20 liter will predominate here. So there will be a dilution which is occurring here. And ultimately the patient will receive FiO2 closer to only 21. Is it clear? This is a concept of oxygen dilution. I think next figure it will be more clear. So oxygen dilution will occur if you don't meet or exceed the patient's minute ventilation and inspiratory flow. Here the patient is breathing and inspiring at a rate of 20 liter. Is it clear? But you are giving him oxygen only at a rate of 6 liter. Okay. So this is oxygen dilution. Now, if you're using a high flow device, what is it? The same thing. 20 liter he's breathing, he's getting 21%, but he's being kept a high flow device. What is that? 60 liter. And you have set up in the Hhfnc the FiO2 of 45. Now, which will be he receiving? He'll be receiving this 45 because that is the high flow. Is it clear? So that is the concept of oxygen dilution. So that oxygen dilution will be less in high flow devices. Is it clear? So that is a concept of oxygen dilution. Now this is also very important because only if you know this, when you're putting a patient on Hhfnc, you will be more careful. Otherwise, you will think like it's like a simple O2 or a nasal prong you're giving to the child. No, lot of things are going inside the child when you're putting a child on a high flow device. So what is this nasopharyngeal oxygen reservoir? So now again you give high flow through that nasal cannula. It is washing out. This is a nasopharyngeal space. This nasopharyngeal space will contain the air which is breathing out also. Clear? And this is acting as a dead space also. What I told you, it's acting as an anatomical dead space also. Okay. So you give something very high flow. What will happen? It will entirely wash out this dead space. And this area, this nasopharyngeal area, will be almost acting like a reservoir, like the reservoir of a non-rebreathing mask I have shown you. And this will be filled with whatever percentage of oxygen you are giving. Suppose in Hhfnc you have kept it at 45, this will become filled with 45% oxygen. Is it clear? And so the delivery into the lungs will be fixed. So that is the problem. That is the importance of the nasopharyngeal. So the nasopharynx is acting as an oxygen reservoir in the case of an HHFOC. Okay. So these two things you have to understand. And apart from that, the simple heating and humidifying will reduce the nasopharyngeal resistance. You should understand, in children compared to adult, 50% of the total resistance is attributable to the nasopharynx and the nasal cavity. Okay. So when it is heated and humidified, that will decrease. And then what happens? It will increase the resistance. So when you heat and humidify it, the resistance will be decreased. So, dry, I told you, you yourself imagine when it dry and cold air you are getting into your airways. And then since it is heated and humidified, it will improve your mucociliary function. Okay. And this is very important. If you are not giving humidified oxygen, even for short periods, it will result in worsened function of the epithelial cells and all the inflammatory indices will increase. Clear? And naturally what happens, Asna, you are breathing in air from the atmosphere. Okay, of course it is humid and the warmness depends upon the atmosphere. Anything is taking place inside your airways, Asna?
Mucociliary action.
Yeah, in your airways also there is a mucociliary function. So what is happening to the air which you are breathing in?
Filtered.
Yeah, it is getting heated and humidified. Clear?
Yeah. Yes, ma'am.
Yeah, in your airways, in your upper airways, the main function is heating and humidifying to the normal temperature. Okay, but this function will be impaired when you have a disease process. Clear? And in that you are giving extra oxygen, which is again dried and humidified, which is adding to the that is the body cannot handle it. Is it clear? So the body has to use more metabolic work for it. So why did I depict all these in a single slide is the mere purpose of heating and humidifying itself will create lot of good that is oxygen improvement in the patient. Is it clear? So you should always think you have kept an nasal prong to a child which is coming from the central oxygen point. It is not heated and humidified. Okay. So once the purpose is served, try to wean him off immediately. Okay. Otherwise, it can result in worsening of the condition. But even in indigenous CPAP, the same thing. You are not humidifying it. Don't think you are adding water to that oxygen trap. It is getting humidified. No. You are giving only dry and cold air. Okay. And this is something I have already told you. Hhfnc is delivering a PEEP, but that is not a definite PEEP as you see in a CPAP. Okay. And that will vary with the flow rate, the diameter of the nasal cannula, and higher pressures can be delivered when the mouth is closed. Even when you give CPAP, I told you are giving the biggest nasal prop. And if the baby is crying and opening the mouth, that amount of pressure is gone. So you will try to maintain the mouth in a closed position. How will you maintain the mouth in a closed position? Saira, Samiha, Arule, how do you maintain the mouth in a closed position so that you get a maximum PEEP in the newborn and all? So this way, the second figure. What is the second figure? You keep a poopsie or something so that you can quieten the child so that the pressure delivered will be adequate. Okay, the same thing in Hhfnc. Hhfnc also, if you want to make sure that at least some amount of PEEP is delivered to the baby, you can try to keep the mouth closed by offering a poopsie. Okay, and fluoride versus PEEP, just to make you understand, these are for, don't get worried by seeing so many graphs. You'll be thinking, Susi madam is putting all the graphs and creating confusion. But these graphs, just look at the y-axis, this is the pressure, and x-axis is the flow. It only shows that, see, look at this graph. A preterm neonate, as the flow increases, the pressure increases. So only when the flow increases, you will deliver a PEEP. So this is shown in an adult also. Flow is increasing, the end expiratory pressure is also in. This is compared with the flow rate, and this y-axis is the end expiratory pressure or the positive pressure. Is it clear? So that is why the increasing the flow rate will increase the positive airway pressure. Which positive airway pressure? End expiratory pressure, or what we call P. But that is not very definite because it will vary with the whatever factors I have told you. It will vary with the weight of the patient, the flow rate, the diameter of the cannula cap, and whether the mouth is open or not. So all these will vary. Okay, this is another picture also showing, like if you keep it at 30 liter per minute, this is the pressure. If you keep it 40 liter, little more pressure. If you keep it 50 liter, little more pressure. Okay, that is a end expiratory pressure. Okay, now these, I think the coming slides I will just rush through because Dr. Anu will be explaining in her videos. The composition everybody knows of an Hhfnc system. It is made up of a pressurized oxygen and air blender, that is this thing, and a sterile water reservoir. This is a sterile water. This is very important. This is a water reservoir, and this is distilled water and tubings getting connected to the airway. And this always has to be maintained in a closed system. ഇതിൽ വെള്ളം ഒരു സിറിഞ്ചിൽ തുറന്നെടുത്തിട്ട് ഒഴിക്കരുത്. So that will add to the contamination. So you have to always fill water in the chamber as a closed system. And this is the main thing. This is the main thing, part of the Hhfnc machine, which is heating and humidifying it. And of course, the non-occlusive nasal cannula. Okay. So this is again picture. This is a heater and humidifier. You can just slide in. You can just slide in the heater, humidifier to this thing. And this is the thing which is seen on the panel. All of you know this is a temperature. This is a flow rate, and this is a FiO2. And I think these buttons will be explained in the videos. Okay. So now what are the indications? So what are the indications for giving Hhfnc? And bronchiolitis is a number one because evidence-based studies are for moderate bronchiolitis, but there are few studies for asthma, for pneumonia, for cases of upper airway obstruction, obstructive sleep apnea, and it acts as a bridge to intubation. It's also used for post-extubation support. It's used for post-operative respiratory support, and even in congenital heart diseases. Okay. So by the mechanisms I have explained, it's a role played in all these disease processes, but you have to make sure that the patient is not in an acute life-threatening hypoxemia or hypercarbia, because even bronchiolitis, the studies are there only for a moderate. Severe bronchiolitis will not respond. So we'll come to it. Okay, one important thing which I have to tell here is in congenital heart disease, it really plays a good role, especially in case of left to right shunt lesions. Okay, because you know, if you give a high FiO2, to a left to right shunt lesion, what happens? You know, left to right shunt lesions will present with recurrent pneumonias. Neithu is a left to right some lesions will present with recurrent pneumonias, and you will give if you give, what will happen if you give a high FiO2 to such a left to right shunt lesion child? Neetu?
Madam.
എന്ത് പറ്റും ഹൈ FiO2 കൊടുത്തു കഴിഞ്ഞാൽ? ഒരു ലെഫ്റ്റ് ടു റൈറ്റ് ഷണ്ട് ലീഷൻ ഉള്ള ഒരു കുട്ടി ന്യൂമോണിയ ആയിട്ട് വന്നു. You are giving 80%, 70% annual FiO2. What will happen? Apart from the problems which I have shown you, which I told about, Kiran has told about oxygen toxicity and atelectasis, what else will happen? Not acidosis. What will happen? What will happen to the pulmonary vessels? When you give so much of oxygen, there will be pulmonary dilatation or constriction. Oxygen is acting as a vasodilator. Understand? Pulmonary vasodilator. So what will happen? Pulmonaries are vasodilating, the right ventricular pressures will come low. So left to right shunt will increase, and these patients will go on to cardiac failure. Okay, so we have to be very careful in titrating the FiO2 of such a left to right shunt patient when they come with pneumonia. Is it clear, Needu?
Yes, madam.
So Hhfnc is very good in that. You can actually see pneumonia is there. You need to give a high flow. You need to give a heated and humidified, but you keep the FiO2 to 40 or even 30. Clear? So pulmonary vasodilatation will not occur so much that a left to right shunt lesion is not precipitated, and suppose the patient is not in failure. Okay. Even in patients with failure, you don't want the right ventricular pressures to come down more. Is it clear, Needu?
Yes, madam.
Okay. And this is very important in the emergency, like in the casualty. Suppose a patient comes with a respiratory distress and like you feel that the patient is needing an endotracheal intubation. By the time you keep arrange everything, you can start the patient on an Hfnc. Okay. And this is the most important, and I'm not going to explain again about it because I already told in my last class, pre-oxygenation and apneic oxygenation during intubation. So Hfnc is very, very important in providing pre-oxygenation and apneic oxygenation. Okay, already I have told and discussed about apneic oxygenation during intubation. Now, find out what are the contraindications for Hfnc. So Hfnc, it's a nasal cannula which is kept on the external nares. So upper airway abnormalities, including like facial choanal atresias, then facial bone or skull-based trauma, hemodynamic instability. If it is a severe shock requiring inotropes and all, better not to put on Hfnc. Life-threatening hypoxia, and already there is a pneumothorax or a pneumomediastinum. You have to be very careful on your flow rates, because if your flow rate increases, sometimes there could be trauma, barotrauma. So already pneumothorax, preferably don't keep it. Then copious secretion. It's very important. Like today we have a child in the ICU who has come with a child having swallowing dysfunction. So there were very much copious secretion. So copious secretion is there. The child is not able to maintain the airway. Actually, the Hfnc and NIV will not do good. You should not waste time, and you have to intubate the child, because only invasive ventilation will take care of the secretions. Very important. You have to understand copious amount of secretions. The child is improving, it's good. But the child is improving with a simple mask or even with a hood, it is good. But otherwise, copious secretion with too much work of breathing, the child will not tolerate an Hfnc or a NIV. You have to do an intubation. And similar thing, when there is an active vomiting or an abdominal surgery or an abdominal anything, because whatever air you are giving in the Hfnc is also entering into the stomach. Okay, so that will cause problem. And this is also very important. Please remember, Needu, evidence of severe carbon dioxide retention. Suppose you have done a blood gas and there is significant hypercarbia. They tell even if the CO2 is more than 50 and there is a life-threatening hypoxia with a hemodynamic instability, better not start on an Hfnc. You directly go in for other modalities. Clear? So this is very important. Even because Hfnc, Needu, namal edi patient use cheyyunnathu, the patient should be conscious, alle? The patient should be having a spontaneous respiration. The patient should have its own spontaneous respiration, because we are only supporting. So any patient who has got an impaired mental status, decreased spontaneous respiration, and loss of airway protection, has got an increased risk of aspiration and hemodynamic instability, we should not use Hfnc. Okay. So these are the things in which we should not use HFNC. So patient selection has to be done. Then only there will be success for the HFNC. So there should be no contraindications for HFNC. And you have to think of the indication so that the patient will tolerate and it's expected to reverse that current respiratory status. Okay. So when you select the patient, you should have an idea about the indications and contraindications. Otherwise, it will lead to high failure rate of HFNC. Okay. Now, how do you initiate HFNC therapy? Kiran Kumar, how are you going to initiate an HFNC on a patient? What is the flow rate you start with and how do you increase it? Already put up the first line, so it is easy. Kiran.
Madam, 1 liter.
Okay. You can even start with 0.5. No need to go to 1 liter because I told you now, if it is a small child, the minute ventilation will be less. Clear? So you need to give only something more than the minute ventilation. But you should be very careful. In a diseased child, sometimes there will be tachypnea. So the respiratory rate is more. Naturally, the minute ventilation will be more, provided the tidal volume is not very less. Clear? So you can even start with 0.5 to 1 liter per kg, but standard you're starting with 1 liter per kg. And then you are giving a maximum FiO2 of only 40. Kiran, understand? And very rarely there are situations which we are starting 60. Very rarely. But it's always preferable that you start the maximum FiO2 40. You can increase it to 60. But within 1 or 2 hours, once the patient is stable, you have to bring down on the FiO2. That is very important. Okay. And then what you do, Kiran? Second line also I gave you in order to reduce the time delay. What is it? Kiran? Suppose it's a 10 kg child and you started with 10 liters.
10.
Then what you do?
Maximum 2 liter.
Maximum, what is because it's a 10 kg child, 1-year-old child. Suppose the patient you have started and how long you will wait for the improvement?
20.
Already written in the second line, you wait for 10 to 15 minutes or 10 to 20 minutes. Okay. So after that, if you see there is no much improvement, you can increase slowly. So you can start increasing from 0.2 to 0.5 liter per kg per minute every 10 to 20 minutes to a maximum of 2 liter per kg per minute. But still, in a 10 kg child, the maximum, what is the maximum permissible flow rate which is accepted according to guideline? 1-year-old child, 10 kg. How much you can give?
20.
Kiran, you are doing it, alle?
20.
In our ICU. You cannot go on escalating. You cannot go on just escalating every 10 to 20 minutes. You have to keep a maximum limit. What is that?
20 liter.
20. Maximum 20. It's preferable that 15. Okay, you cannot give more than that. Okay. And maximum flow rate which is accepted in the newborn is 6 usually, but you can even make maximum only up to 8 liter. Is it clear? But usually we'll stop with 6 liter in a newborn. Infant, as you told, it is 20, but be on the safer side, you increase only up to 15, but some cases we have to increase up to 20. Okay. And older child, it's only up to 25. Uppa Kiran, how much you can increase in adult? Adult എത്ര വരെ പോവാം? Adult cannula കണ്ടിട്ടുണ്ടോ? കളർ എന്താണ്? എന്തോ എത്ര വരെ പോവാം? എത്ര ലിറ്റർ വരെ പോവാം? So that is air oil അവിടെ സെറ്റ് ചെയ്യുന്ന സ്ഥലത്ത് നമുക്ക് നോക്കാം. അതിൽ അത്ര ലിറ്റർ വരെ അത് വരത്തുള്ളൂ. Have you tested?
No, madam.
So maximum up to 60 liter only you can give. Okay. So this is very important because you cannot just go on escalating it. Maximum infant is 20 liter, pediatric 25 and adult is 60 liter. Okay. And maximum FiO2 recommended is 60, but usually we should come down very quickly and come to the baseline of 40. Everything is okay, you have to again bring it down. And FiO2 has to be maintained depending upon the clinical condition, usually between more than 94. And this is the HFNC cannula that I already told. The size of the cannula should not exceed the 50% of the nostril and divided. It is available in different forms. And this is the cannula. Red is for what? Red. You should know the color coding also. Red, yellow, purple, and green. Okay. Red is for premature. Yellow is for newborn. I think this is from the Fisher and Vehicle, which we have HFNC machine. Purple for the infant and green for the pediatric. Okay. So this is just to show you that actually, see that the nostril distance has to be, they have got a, what is that, color coded paper, and actually we have to measure the the measurement cannula size depending upon this, and then we have to select it. But roughly, like, you have a color coding which is actually told by me. But ideal situation, you have to look at the approximate size by comparing it with this sheet. Okay. Now, this is the latest guidelines which have been set up, and you can just understand, like, less than 5 kg, 6 liter you start, and maximum is 8, as I told you. 5 to 10 kg, you start with 8, the maximum permissible is 15. So that is what Kiran, 20 പറഞ്ഞപ്പോൾ ഞാൻ പറഞ്ഞു 15 വരെ maximum, because up to 10 kg, the maximum recommended now is 15. 10 to 20, maximum is 20, although previously they used to tell up to 25. And now 20 to 40, starting is 25, but maximum you can go up to 40. But when you read the studies, you can understand that most of them go up to maximum of only 25. Because the higher rates you put, you have to be more monitoring the child. Okay. And more than 40, I told you adult, the maximum flow rate is maximum up to 60. So this also you need to keep understanding. Okay. And this is actually, you all know. So that is again the red one. Red one is 8. The yellow one is again 8. Purple one is 20. And the pediatric one is 25. Apam, you should actually know. Ningalore neonatal yellow ittita adil kuda flow rate 20 set cheyidu vekkalle. Adana vere prashanam. Did you understand, Kiran? Kiran?
Yes, madam.
So yellow cannula ittita adil kuda flow rate evade etra vare maximum vekkavollu? 8. മനസ്സിലായോ? അപ്പൊ യെല്ലോ ആണെങ്കിൽ 8 വെക്കാവുള്ളൂ. ഇപ്പൊ നിങ്ങൾക്ക് അതിൽ കൂടുതൽ കൊടുക്കണമെങ്കിൽ you have to go for the purple one. This is very important because they have actually made the diameter of the cannula setting into all these conditions. Okay, so this you have to be careful, and the color coding actually has to be followed strictly. Then only we'll get the desired results. So you should never forget about, when you put a patient on an HFNC, never forget about the heating unit. You have to look whether the heater is functioning, whether it is getting humidified. The water reservoir and the humidifier is there. The blue tubing is okay. The nasal interface is okay, and you can feed the patient. And so you have to have a check on the humidifier. You have to have a check on the entire system, and the patient is put on HFNC. Okay. Now, what all you will monitor in the patient, Kiran? What are you going to monitor? Whether the patient is improving or not? Kiran Poyo. Ramisa, what all you will monitor?
Saturation.
Saturation.
Rate,
Then respiratory rate. Work of breathing. Okay. That's the usual things we look at. Good. Heart rate. Okay. So these are the things which you are going to monitor. That is respiratory rate, heart rate, work of breathing, and SpO2. And within 2 hours, you put the patient on HFNC and look for improvement within 2 hours. Okay. And and within 2 hours, the patient should improve usually. And then we have to reduce the FiO2. So that means once you put a patient on a non-invasive ventilation, you don't just go away. You look, if the patient is not improving within 1 or 2 hours, you have to escalate it to the other respiratory modality. Okay. So this is just to show that FiO2 required to maintain SpO2 in the target range, and you have to decrease it to less than 40. FiO2 has to be decreased to less than 40. So heart rate and respiratory rate has to decrease to about 20%, and work of breathing also should improve. അപ്പൊ ഇത്ര ഓർത്താൽ മതി. സെറ്റ് ചെയ്തേക്കുന്ന റെസ്പിറേറ്ററി റേറ്റും ഹാർട്ട് റേറ്റും 20% എങ്കിലും കുറഞ്ഞിരിക്കണം. അതാണ് പറയണത്. ഓക്കെ. So what is a good response? What is a good response? Good responders to HFNC will usually show all these improvements within 60 to 90 minutes. 60 എന്ന് പറഞ്ഞാൽ 1 hour, 90 എന്ന് പറഞ്ഞാൽ 3 hour. അപ്പൊ മാക്സിമം നമ്മൾ 3 മണിക്കൂർ വരെ നോക്കാം. അതിനപ്പുറം നമുക്ക് നോക്കരുത്. ബട്ട് ഐഡിയലി ടേക്ക് എ ഡിസിഷൻ അറ്റ് ദി എൻഡ് ഓഫ് 2 hours. If the patient is improving or not improving, maximum permissible is up to 2 hours. Okay, this is what I have already shown. The respiratory rate and heart rate has to decrease from 20% of the baseline. And this is a study which is quoted from the Cochrane database review in 2040. Okay, they actually have found that by 90 minutes, baseline in the first 90 minutes, if they improve, it is a predictive marker for treatment efficacy. Okay, so that is a study which is highly quoted in the literature. And what are the indications to escalate the Hhfnc? So as I already told you, FiO2 is maximum only up to 60%. So you want to increase the FiO2 to more than 60%, or the patient is having a persistent work of breathing. Even after 60 minutes, don't delay. You have to immediately switch over to your higher escalating medium, including the invasive ventilation. And this is already, I have told, it is not decreasing by 20% after 1 hour. You have to be very crucial. Once you put the patient, you have to stand near the patient and monitor. Okay. And if you are in doubt, you take a arterial gas. That is a venous gas also will do. You need to add +5 for the CO2. You take a blood gas, and if it shows carbon dioxide retention, again it indicates that Hfnc is not going to give more hope. And if there is a hemodynamic instability and multi-organ failure, then also you have to escalate it. So you have to periodically monitor, apart from the vitals, heart rate, respiratory rate, SpO2, you have to also do a periodic blood gas, because I told you hypercapnia is persisting. You shouldn't continue with the Hfnc. You have to go with the other modalities. Okay. Now, how will you identify the non-responders? So, Hfnc to failure eye. അതിലും ഭേദം നമ്മൾ ഏതാണ് നോൺ റെസ്പോണ്ടേഴ്സ് നേരത്തെ ഐഡന്റിഫൈ ചെയ്താൽ we will not put these patients on Hfnc. So how will you identify? So it's told that those of the children who are having a respiratory rate above the 90th percentile for it. So there is a chart showing the percentiles of respiratory rate. Okay, so if it is more than the 90th percentile, or if it's so much of tachypnea, initially itself there is so much. Suppose a 1-year-old child is having a tachypnea of 80 per minute. Okay, so that is above the 90th percentile. Or the initial blood gas itself is more than 50. Or the initial venous pH is less than 7.3. So that means hypercarbia, respiratory acidosis, and tachypnea will allow to predict that these patients are probably not going to respond. So better not put these patients on Hfnc initially. Okay. Now, how are you going to de-escalate? Kiran, you have increased and come up, and how will you de-escalate? How long you will wait, Kiran? When do you want to de-escalate? So 2 hours the patient improved, you are continuing the patient on Hfnc. The FiO2 is 40%, the flow rate is 15 liters. Patient is stable. Now Kiran is going to wean the patient. How are you going to wean, Kiran? Kiran.
Yes, madam.
How are you going to wean? I told all the values. FiO2 40. Flow rate 15.
Flow rate, saturation.
What are you going to decrease first? And how are you going to de-escalate? And what time you are going to de-escalate?
FiO2 first കുറയ്ക്കുന്നു.
എപ്പം ഡീഎസ്കലേറ്റ് ചെയ്യും? ഇന്നിപ്പോ പേഷ്യന്റിനെ രാവിലെ 8 മണിക്ക് Hfnc ഇട്ടു, 10 മണിയായപ്പോ സെറ്റിലായി, ടാക്കിപ്നിയ കുറഞ്ഞു, വർക്ക് ഓഫ് ബ്രീതിങ് കുറഞ്ഞു, ഹാർട്ട് റേറ്റ് കുറഞ്ഞു. When will you start de-escalating? അപ്പൊ തന്നെ de-escalate ചെയ്യോ? That it depends upon the primary condition you have put. Understand? So if it is for asthma, yeah, that is very important. If you have put it for an asthma patient, the bronchodilator, the bronchodilator therapy would have made the child better. You can start de-escalation earlier. You are put for a pneumonia and other problems. Might be the resolution takes time. So you have to wait for at least 12 or 24 hours. That means 1 day or half a day. Okay, then only you'll start de-escalating. While de-escalating, what you will decrease first? FiO2 or the flow rate?
FiO2.
Or both together?
FiO2.
But if it is like FiO2 is only 40 or might be 35, 30 ഒക്കെ ഇട്ടിട്ടും ഫ്ലോ റേറ്റ് മെയിൻറ്റെയിൻ ചെയ്യുമ്പോൾ ഫസ്റ്റ് if the FiO2 is at a lower level, you start de-escalating on the flow rate. Okay, how will you de-escalate? 15 ലിറ്റർ ഉള്ള എങ്ങനെ കുറയ്ക്കും?
For 1 liter.
15 ലിറ്ററിനെ എങ്ങനെ കുറയ്ക്കും? അപ്പൊ കിരൺ ചെയ്യണല്ലേ ICUല്?
Yes, ma'am.
അപ്പൊ എത്ര കുറയ്ക്കും 15നെ? You have to
One-
decrease it hourly or 2
With
hourly.
one-
You have to,
Hourly 1 liter വെച്ച് കുറയ്ക്കും.
അങ്ങനെയല്ല 1 ലിറ്റർ എന്ന് പറയില്ല, per kg ആയിട്ട് പറയണം. Okay, Kiran, then only it will be correct. Okay. So once the patient is stable on HFNC for 12 to 24 hours, consider weaning usually. But if it is an asthma improved by bronchodilator, you can wean earlier. Is weaned first if it is on the higher side. Okay. Like you have kept it like 60, I told you maximum. 16 anengil you will try to wean it to 40 and then you will decrease the flow rate. And how long, how much you decrease it? 0.2 liter per kg per minute. So 10 kilo കുട്ടിയാണെങ്കിൽ എത്ര കുറയ്ക്കും കിരൺ?
2 liter ആണ്.
2 ലിറ്റർ. അതിൽ എത്ര മണിക്കൂർ കൊണ്ട്? 1 hourൽ കുറയ്ക്കാം. മനസ്സിലായോ? അപ്പം പെട്ടെന്ന് ഇംപ്രൂവ് ചെയ്യുന്ന പേഷ്യന്റ് ആണെങ്കിൽ 2 ലിറ്റർ in 1 hour, നെക്സ്റ്റ് 2 ലിറ്റർ in other hour. അങ്ങനെ കുറയ്ക്കുമ്പോൾ you will by 6 hours or by 4 hours you can bring it to low values. Understand? So this should be guided by the work of breathing and the oxygen requirement. Is it clear? This is the same thing we told to escalate also. 0.2 to 0.5 liter per kg per minute you escalate it over 10 to 20 minutes. De-escalating you go by the 0.2 liter per kg per minute over 1 or 2 hours. Okay. And once you reach the flow rate of 2 liter per minute, the HFNC can be discontinued and you can change it to a low flow device. Is it clear? By the time, it's not very mandatory that FiO2 has to be reduced to 20. Is it clear, Kiran? FiO2 can
Madam.
remain at 40 or even 35 or 30 because you are giving the O2 prong which can deliver the same FiO2. Is it clear?
Okay,
So our
madam. Yes,
primary
madam.
concern is to decrease the flow rate. Is it clear, Kiran?
Yes, madam.
And the FiO2 also has to be decreased, but primary concern is the flow rate. And even after discontinuing the HFNC, you have to continue pulse oximetry monitoring for 30 minutes continuous. And then 2 hourly you have to monitor so that the patient is not going back into, is not worsening. Is it clear? So that is de-escalation. And this I won't discuss because this is just a, what is that, a protocol which is set up by the this biomedicines journal. But it was not, it's not actually approved for use in the whole world. But they have just set up it based on the, I just took it up to show how they have scored it and how they have divided it. Those which is requiring, they have scored the respiratory distress, those requiring low flow, those requiring high flow, and those requiring the other invasive and non-invasive ventilation. They have scored it by what is called as a pediatric early warning score. So all of you have to go and read about the pediatric early warning score. This is a very important score which can be made use of in our casualty and even in our respiratory distress patient to know for the improvement or worsen. Okay, this is a good score. And this is color coded also. So I'm not going details into it. Okay, now this is a flow chart. This you should know. Comparing the physiological effect of what is COT is a conventional oxygen therapy, HHFNC and the CPAP and NIV. So when you look into it, see, when you look into all these conditions, see, again, it is a reinforcement that your high flow nasal cannula, optimum gas conditioning, 3+. Washout of nasopharyngeal dead space, 3+. Improvement in mucociliary clearance, 3+. And flow and oxygen concentration setting, what we told, inspiratory demand is met, 3+. So this is actually, and this compare the standard oxygen therapy, these things are not there. Is it clear? None of these things are there for the standard oxygen therapy. And see the continuous positive airway pressure. Compare the gas conditioning, that is only 1+. The washout of nasopharyngeal space is also 1+. Mucociliary clearance is not there. Okay. So, but the only thing is just understand where is it PEEP, the PEEP delivered, the reduction, the reduced breathing effort, that is 3+ in the CPAP. Okay. So you should know from this that HFNC has got lot of positive high effect condition, even better than an indigenous CPAP. But definitely a bubble CPAP with a heated and humidifier will do better than an HFNC. Okay. So this is already what I have told. So now what are the benefits over NIV? What are the benefits? You know how a NIV is kept, right? NIV is really, you have to keep an interface which is very bulky. Very bulky. This is the orofacial. That is, this is the oronasal interface. This is the nasal interface. See, these are the different types of NIV. It's very bulky, very much non-compliant. So the HFNC is better tolerated. Child can feed, drink, and communicate, and it has got, see, all these things when it is tightly attached, there can be a chance for bed pressure source. So that is not there in HFNC, patient comfort and compliance. And one thing you should know, noise level. See, just imagine when you keep such high flow, what will be the noise level? But actually what they told is that the noise level will be better with HFNC compared to your bubble CPAP and the NIV. Those are having high noise levels than the HFNC. Okay. So that is why, and HFNC, you know, is easier to be kept. So sister not HFNC, she'll be more happy than you tell her to keep an NIV because she has to do a good job to secure this interface to the face. Okay. So this is HFNC in asthma. I think the only point which I want to concentrate on this HFNC in asthma is how do you nebulize when the patient is on HFNC? Neetu, how do you nebulize a child who has been kept on HFNC for asthma? Neetu Poyo. So when you are nebulizing a patient, actually you cannot nebulize with an HFNC in situ because HFNC is a high flow situation. When we have a nebulizer, low flow alveolar ventilation, the aerosol particles will not go inside. So ideally there is no way. Either you have to bring down the rate of HFNC to 5 liter and then give the nebulizer with the HFNC in situ, or you have to take the HFNC temporary and then. So I think that is what we are following. So temporary discontinuation of HFNC or lowering the flow to less than 5 liter should be considered at the time of nebulization. And next slide I have kept like for the quiz question because there is another recent adaptation to the HFNC machine called as the mesh nebulizer. So if you keep a mesh nebulizer in the port of HFNC, you needn't disconnect the HFNC when you give a nebulizer for the asthma. So somebody asked you about a mesh nebulizer that is called as a vibrating mesh nebulizer. See, this is the usual HFNC machine. And adil information vannitta, the humidifier has got a different port. And our port lotana you attach the vibrating mesh nebulizer. See, the thing looks like this, vibrating mesh nebulizer. And I'm not going into the mechanics and physics of the vibrating mesh nebulizer. You should just understand that if there is a vibrating mesh nebulizer, you can nebulize directly with the HFNC in situ. Okay. I think it's getting over. So this is a study which is carried out using vibrating mesh nebulizer, which tells that the delivery of the aerosol particle is good. Then newborn and HFNC, I think all of you are using it for post-extubation, weaning from CPAP, and if it is a respiratory distress syndrome, mild one, and in apnea of prematurity. Okay. Newborn, it's more newborn friendly also. Like, what are the advantages? I told you humidified and warm air will protect the airway mucosa. High flow will overcome the resistance. It will overcome the airway resistance because it is heated and humidified. And since you are giving a fixed FiO2, low FiO2, means adjusting the FiO2, you will prevent the occurrence of BPD, NEC, and IVH. And there is a lot of comfort and pain is reduced. And I told you noise levels are also better than the bubble CPAP. Okay. And the mother can also give KMC. Because other one is all the CPAP machine, CPAP is very bulky on the face. But KMC, there is only a simple, what is that, face cannula, which so that mother can do better KMC. So this is the last slide. So why there is popularity of HFNC is, the only word is patient tolerance and patient compliance is more with HFNC. That's the most important thing why it has become very popular in spite of the lack of evidence-based indications for different disease conditions. Okay. And even popularity with clinical staff. It is very easy to keep. The interface is very nurses and doctors, they are very happy to start a patient on HFNC, and even they are monitoring also well. And so there is an increasing use over the recent years despite the lack of evidence for its clinical effectiveness. But like this is ideally HFNC is having a lot of research scope because many studies are underdone. So actually more studies will come out in the near future, and which will actually make it evidence based so that we have a set of fixed guidelines for implementation of the HFNC into our pediatric practice. Okay, so that finishes it. Thank you. The video.
Okay, thank you, Susie. Though I had some interruptions in between, but whatever I have heard, so many new things was made clear. Even though all our PGs are so enthusiastic about using HFNC because വേണ്ട എന്നൊന്നും ഇല്ലെങ്കിലും HFNC എന്ന് പറഞ്ഞാൽ ഭയങ്കര ഒരു ഇഷ്ടമുള്ളൊരു സാധനമാണ്. അതിന്റെ സുഖം അറിഞ്ഞു കഴിഞ്ഞാല് എല്ലാരും പിന്നെ അത് ഉപയോഗിച്ചുകൊണ്ടേയിരിക്കുന്ന ഒരു സാധനമാണ്. As you rightly pointed out, there's a lot of scope for research and the use of HFNC in different situations. Okay. Thank you so much.
Thank you, madam.
Susie,
Yeah.
നമുക്ക് എത്ര നേരം ഉപയോഗിക്കാൻ പറ്റും? How long we can keep the HFNC?
That's a good question, Sunil. Actually, it can be kept for even depends upon the clinical condition, because usually if the patient is improving, usually we start to de-escalate it within 24 to maximum 48 hours.
Okay.
Because one is like you are giving a very high flow, and second, even oxygen should not be wasted too much. So if you are not, if the patient is not becoming better, you better escalate it to the other higher respiratory therapies. The patient is stabilized ആണെങ്കിൽ നമ്മൾ 24 hours maximum 48 hours ഉള്ളിൽ we have to wean and come out to conventional oxygen therapy.
നമ്മള് സാറിന് ഇവിടെ 3-4 days ഒക്കെ വെക്കാറുണ്ട്. ലെയറിലേക്ക് ഒരു
അതാണ് മാഡം പറഞ്ഞത്, അതിന് ഇട്ട് കഴിഞ്ഞാൽ പിന്നെ ഊരില്ല.
ഡീഎസ്കലേറ്റ് ചെയ്ത് ലെയറിലേക്ക് ഒരു പോസിബിലിറ്റി ഉണ്ടല്ലോ ഇതിലും.
അത് നല്ല പോസിബിലിറ്റി ഉണ്ട്. ബട്ട് ഐ തിങ്ക് ഇഫ് യു ആർ വെരി കെയർഫുൾ വിത്ത് നേസൽ കാനുല ഷുഡ് ഓക്യുപ്പൈ ഓൺലി 50% ഓഫ് നേസ്. പിന്നെ ഒബ്സ്ട്രക്ഷൻസ് ഒന്നും ഇല്ലെങ്കിൽ ഇറ്റ് ഈസ് ആക്ച്വലി സേഫ്. കുറച്ച് നമ്മൾ എവിഡൻസ് ബേസ്ഡ് വായിച്ചു കഴിഞ്ഞാൽ ആക്ച്വലി ന്യൂമോതൊറാക്സ് ന്യൂമോമിഡിയസ്റ്റിനെ ഒക്കെ ഇതിനുള്ളിൽ ഇൻ വെരി ലിറ്റിൽ പെർസെന്റേജ് ഓഫ് കേസസ്. ബട്ട് യു ഹാവ് ടു ബി കെയർഫുൾ. സെക്രീഷൻസ് വന്ന് അടഞ്ഞു കഴിഞ്ഞാൽ ഇറ്റ് വിൽ കോസ് പ്രോബ്ലം.
അത് എപ്പോഴും വെന്റിലേറ്റ് ചെയ്യുന്ന ആണേലും HFNCയിൽ ഇടുന്ന ആണേലും ഈ ഇടുന്നതിന്റെ അത്ര ഉത്സാഹം പിന്നെ അതിനകത്തുനിന്ന് വീൻ ഓഫ് ചെയ്യാൻ കാണാറില്ല.
ശരിക്കും തിരിച്ചാണ് വേണ്ട, വീൻ ചെയ്യാനാണ് ഉത്സാഹം കൂടേണ്ടത്.
അതെ കാരണം അതിന്റെ പ്രോബ്ലംസിനെ കുറിച്ച് ആലോചിക്കുമ്പോ നമുക്ക് അങ്ങനെ ഒരു ഇരിക്കപ്പുറതി ഉണ്ടാവണ്ടേ അല്ല.
അല്ല, ഇതിലിപ്പോ ഇമ്പ്രൂവ് ചെയ്തില്ലെങ്കിൽ ഒരു എക്സ്റേ പോലും എടുത്ത് നോക്കില്ല, ലെയറിലേക്ക് എന്തെങ്കിലും ഉണ്ടോ, കോംപ്ലിക്കേഷൻ വല്ലതും വരുന്നത്, അതുപോലും ചെയ്യുന്നില്ല.
കാരണം അതിൽ മാക്സിമം നമ്മള് 48 to 72 hours വരെ നമ്മൾ ചെയ്യാൻ പാടുള്ളൂ യൂഷ്വലി. ഇംപ്രൂവ് ചെയ്യണില്ലെങ്കിൽ യു ഹാവ് ടു ലുക്ക് ഫോർ ദ റീസൺ ബിഹൈൻഡ് ഇറ്റ്. നമ്മുടെ അനുയുടെ ഒരു വീഡിയോയും കൂടെ ഉണ്ട്, അത് എനിക്ക് തോന്നുന്നു നമ്മള് ഗ്രൂപ്പിൽ ഷെയർ ചെയ്യായിരിക്കും. അനു ഒരു ലൈവ് വീഡിയോ ഞാൻ എടുത്തിരുന്നു, അനു HFNCയുടെ ഇതെല്ലാം ലൈവ് ഡെമോ കാണിക്കുന്നത്. സോ ഐ തിങ്ക് മാഡം
അത് കൊറേ സമയം മതി കൊറേ സമയം എടുത്ത് റീഡു ചെയ്തൊരു സാധനമാണ്. ആദ്യം ഒന്ന് എടുത്തു, പിന്നെ അത് അതിന്റെ അല്ലെ ഡിസ്ക്രിപ്ഷൻ പിന്നെ വീണ്ടും ചെയ്ത്
പിന്നെ എടുത്തില്ല
ആ.
മാഡം. ഞാനും അതുപോലെ
ആ.
തന്നെ മീൻസ് പറഞ്ഞത് തന്നെ വെച്ചു. ഓഡിയോ വലിയ കുഴപ്പമില്ലായിരുന്നു മാഡം.
ആണോ? ഓക്കെ
പിന്നെ
ഓക്കെ. ആ.
എടുത്തില്ല, പിന്നെ എടുത്തില്ല. ആ.
Okay, okay. So everybody make it a point to see the video. നമുക്ക്
ഗ്രൂപ്പിൽ
ആണോ അതോ? ആ, ഓക്കെ ഓക്കെ.
വീഡിയോ
ശരി
ഗ്രൂപ്പിൽ
ശരി.
മാഡം.
So all of you have a good sleep today. Tomorrow come fresh, come a little bit early, be on time, and also എല്ലാരും ഇത്തിരി നേരത്തെ വന്നാൽ നമുക്ക് റൗണ്ട്സ് ഒന്ന് നേരത്തെ ഫിനിഷ് ചെയ്താൽ കുറച്ചുകൂടെ സമാധാനമായിട്ട് ഒക്കെ പ്രോഗ്രാമിന് കയറാമായിരുന്നു എല്ലാവർക്കും. ഓക്കെ, താങ്ക് യു. ഗുഡ് നൈറ്റ്.
താങ്ക് യു മാഡം.
താങ്ക് യു മാഡം.